Welcome to the Life 2021 Nephrology Campus. My name is Peter Stenvinkel. I work at the Karolinska Institutet in Stockholm, Sweden. Together with my colleague, Professor Wanner from the University Hospital of Würzburg in Germany, I am chairing the Life 2021 Nephrology Campus, an opportunity to get updated on current trends in nephrology during the pandemic. Under this format, we offer you a series of 18 webinars, and today I am honored to chair the third webinar in this series. Before we start, I'd like to introduce some housekeeping rules. Please feel free to ask your questions at any time via the chat function of GoToWebinar in the right bottom corner. Today, it's a pleasure for me to introduce to you two erudite speakers, Professor Alan Collins and Dr. Natalie Borman. Together, they will talk about applying dialytic modality choices to preserve cardiovascular health. And with this, I'd like to start by introducing the first speaker, Dr. Alan Collins, who is a Senior Chief Scientist at Fresenius Medical Care and Professor Emeritus from the University of Minnesota. And Alan Collins will talk about cardioprotection, volume control, both from loading and unloading results in hypertensive control. Dr. Collins, please.
Well, thank you, Peter. It's a pleasure to be with all of you today. Dr. Borman and I will do a back-to-back presentations, one about the underpinnings of how volume loading and unloading impacts the heart and the dialysis patients. And Dr. Borman will provide some case studies to show you these effects. Now, because we're all interested in integrity and compliance with honest presentation of materials to protect our patients and deliver the best care possible. So volume control is really in the causal path for cardiac outcomes. And one of the main findings in the general population, dialysis population, has been that there's been slowing and improvements of cardiovascular outcomes in recent years. Cardioprotective treatments have received little attention in the face of consistent volume overload with associated hypertension. So from this aspect, new approaches for dealing with volume control need to be addressed. The care paradigm in the dialysis population needs to advance then, addressing expanding evidence, particularly from the non-dialysis heart failure population, where we can learn a little bit more about the pathophysiology of volume loading and how it affects the heart. More frequent hemodialysis can improve the volume control and cardioprotection in this complex population, which will be demonstrated in the case studies. So how does volume control impact outcomes in heart failure in the dialysis population? And how does volume loading and unloading play out in the dialysis population? So in this figure, this is heart failure outcomes in the general population. On the left side of the slide is the effect study, which looked at over 9,000 patients, showing that for each subsequent heart failure hospitalization, your mortality risk goes up. Same thing is on the right side from another study. These are exactly the same findings that you see in the dialysis population. For each additional cardiovascular hospitalization, there's an increasing risk of death. So the heart failure hospitalizations show that volume and pressure overload are in the causal pathway to decompensation. I'm going to show you this. What role does pulmonary artery pressure play in this decompensation of heart failure in the general population? And could these principles of volume loading and pressure loading of the heart also occur in the dialysis population? Now, in this figure from the pivotal study that looked at New York Heart Classification 3 level patients with heart failure, they looked at those heart failure patients who were followed prospectively with right ventricular pressure monitoring, looking at those that had both systolic and failure, and what was the pressure profiling over time. And here it was up to 80 days follow-up. You can see on the left side of the figure, those who did not have heart failure-related events, either hospitalizations or emergency room visits, had very stable pulmonary artery diastolic pressures, ranging somewhere between 24 to 26 millimeters of mercury. However, on the right side of the figure, those individuals who ultimately were hospitalized with a heart failure-related event or visited the emergency room for that event, that just before the event, the diastolic blood pressures in the pulmonary artery blood pressures increased rapidly. This was an important finding that contrasted between those that were stable and those that were unstable and ultimately had events. Now, this particular observation was then applied in what was known as the CHAMPION trial, using a CardioMEMS pulmonary artery pressure monitoring device to guide heart failure therapy. In the control group, the actual pulmonary pressures were ignored in the treatment, and those that were in the treatment period actually had their therapy monitored and adjusted based on the pulmonary pressures. You can see, compared to their historical hospitalization rate 6 months before they started the study, the individuals had a 37% reduction in the risk of hospitalizations when their heart failure therapy was guided by the pulmonary pressures. This same study was just published in June of this year with a European cohort, with the CardioMEMS European Monitoring Study for Heart Failure. With the same exact format, with a 12-month follow-up period looking at hospitalizations before and after pulmonary artery pressure guided therapy was used to treat the patients, there was a even greater reduction in the hospitalization rates, some 32% or 62% reduction, markedly improving the outcome of these patients. So these observations allowed us to understand the pathophysiology under heart failure in the non-dialysis patients. Repeated hospitalization events were associated with increased risks of death. Changes in the pressure and volume loading the heart precede the acute decompensation events. Pulmonary pressure guided therapy improved the outcomes. And, excuse me, went too fast. The same pathophysiologic principles may actually apply to the dialysis patients, and I'll show you that on this next slide, which you've already seen. So on the left side of this slide is a pressure tracing done almost 10 years ago in a study of 26 dialysis patients, showing an 8-day cycle where the HD is the hemodialysis events. This looks like the right ventricular systolic pressure, estimated pulmonary area diastolic pressure, and the right ventricular diastolic pressures. Noting that during the dialysis treatment where ultrafiltration occurs, the pressures fall. Then between the dialytic periods, the pressures rise, and particularly in the red box over the long weekend or the long dialytic interval, where pressures rise until the next hemodialysis treatment. From this aspect, the heart is cyclically loading with fluid and pressure and unloading 3 times a week, week after week after week. Now, this pressure loading phenomenon looks exactly like the pressure loading that occurs in the non-dialysis heart failure population before they have heart failure events, such that the hemodialysis procedure is saving the patients from being hospitalized until these pulmonary pressures and volume overload get so excessive that the patients are ultimately hospitalized. Now, on the left side of the figure is the well-known studies by Dr. Fleif and her colleagues, which showed this association between the ultrafiltration rate during the dialysis procedure and mortality risk. What is equally important and represents 93% of the time in a week off dialysis is the fluid loading that occurs in this study by Zoccali et al., showing that chronic fluid loading and loading of the heart is also associated with a mortality risk, such that 2 things are going on simultaneously. Excessive ultrafiltration rates can lead to cardiac stunning and risk, but chronic fluid overload here over a year is also compounding the effects and leading to increased mortality risk. Now, this pathophysiologic slide shows you on the top chronic loading between dialysis treatments, which is 93% of the time, with sodium and fluid contribute to uncontrolled hypertension, right and left ventricular hypertrophy, heart failure, and hospitalizations and death. In the lower part of the figure, the intra-treatment ultrafiltration rates, or cardiac unloading, which has received much more attention, leads to hypotensive episodes, organ stunning, cramps, nausea, vomiting, patients not feeling well. And if they sign off early, they maintain and they continue to be fluid overloaded. So the mechanisms that you've just seen have 2 types of therapeutic interventions. We can either increase the frequency and time of treatments to deal with cardiac loading, and we can increase the number of time in a week. So to summarize at this point, persistent loading in hemodialysis contributes to hypertension, and cardiac loading and unloading are have equally adverse effects. Volume overload in the hemodialysis population is cyclical, repeatedly stressing the myocardium and the fibrous structure of the heart. Pulmonary hypertension is in the causal pathway of both of these complications. Effective cardiovascular disease protection should address volume loading as well as unloading. More frequent hemodialysis treatments can adapt to address these cardiovascular disease efficacy approaches and patient adaptation to therapy. Thank you, and back to you, Peter.
Thank you, Alan, for this really interesting talk. And I'm sure this talk has led to a lot of questions from you. I'd like to remind you that you should feel free to ask your questions at any time via the function of the go-to webinar in the right bottom corner. So now let's move on to the second talk. And I'd like to welcome Dr. Natalie Borman at Queen Alexandra Hospital in Portsmouth, United Kingdom. And Dr. Borman, she will present on the role of frequent hemodialysis and cardiac failure. Natalie, please.
Thank you very much. Thank you, Dr. Collins, for your excellent talk and for setting the scene for the next few slides, where I'm going to put this into practice and show you how we can use more frequent hemodialysis to stabilise and treat cardiac failure. So I'm going to use a case-based example for this, and the first case I'm going to explain to you is one of left-sided cardiac failure. So this is a case of Mrs. E, a real patient in our programme, 77 years old and 80 kilos. Unfortunately had a failed transplant. In fact, during her transplant, she developed PTLD and had to have chemotherapy. At the failure of her transplant, she went on to peritoneal dialysis for 2 years, but unfortunately had sustained severe left ventricular failure, possibly due to her chemotherapy, and had an ejection fraction at 20%. Therapy was coming very tricky with her. She was having multiple episodes of loss of consciousness, was having frequent hospitalizations, so much so that the cardiologist decided to insert a biventricular pacemaker. At this stage, we also switched her to hemodialysis because fluid overload was becoming an increasing problem and her ultrafiltration on PD was no longer adequate. Her blood pressure at this time was exceptionally low, despite being severely fluid overloaded. And in order to sustain her on hemodialysis, medications began to be stopped. Her ACE inhibitor was stopped, her beta blocker was stopped, purely because she was not tolerating the fluid off on dialysis, dropping her blood pressure and requiring fluid boluses. So subsequently, she was becoming more and more fluid overloaded. And at this point, we started to discuss whether we were reaching the end of her life. To show you some parameters of where she was in November 2014, her ejection fraction was less than 20%. This was on PD and when her biventricular pacemaker was inserted. I want to really draw you to the right-hand side of this slide because this is what the patient feels. She was having blackouts, breathlessness, using a mobility scooter and was severely overloaded. By 6 months on, her ejection fraction was now only measuring at 10%. She was having intermittent hemodialysis and all her cardioprotective medications had been stopped. She was blacking out on dialysis, having very low blood pressure, and her overload was worsening. I just want to remind you at this stage of this schematic, which Professor Collins has shown us already, and we have to think that she's fitting very much to both sides of these cycles. She already has severe cardiac failure, but this chronic fluid overload state is perpetuating the worsening of her heart failure and leading to more and more hospitalizations and subsequently potentially to her death. Fluid overload on her sessions was causing attempts to remove large volumes of fluid and raising that ultrafiltration rate, which we've already seen is bad for outcomes. But then she was dropping her blood pressure, becoming symptomatic, and really having a terrible time on dialysis. Her quality of life was exceptionally poor at this stage. At this point, she wasn't entirely keen to enter end of life phase, so we agreed that she would increase her number of sessions in centre to see if we could reduce the fluid coming off per session and improve her symptom control. Over the next 6 weeks, with 4 sessions a week, we managed to remove 14 kilos of fluid from her and increase her stability on dialysis. Her symptoms improved, and fortunately in that 6 weeks she required no admissions to hospital. Now looking at her parameters, this was in 2015, we'd managed to achieve an improvement to 17.8 in her ejection fractions. Still poor, but as I've mentioned to you, her symptom control was improving. At this stage, she was doing really well on 4 times a week, but actually what was now impacting on her quality of life was the travel time to dialysis, the time spent away from her husband, and she'd swatched her mobility scooter for sitting in the transport to dialysis. So in discussions with her and her husband, who was also elderly, we decided to attempt to train them for home therapy. They both did exceptionally well. She was using a tunneled vascular access catheter. We hadn't quite been brave enough to try and fit a fistula at this stage. And she trained for home dialysis and went on to 6 times a week therapy. A year into this therapy, she had had 0 hospital admissions, had no edema, was maintaining her blood pressure. We'd reintroduced her beta blocker, and she was actually walking with the aid of just a stick. She was doing really well on home therapy and feeling a lot better. Another year into therapy, we'd seen her ejection fraction stabilise, if not improve a little further. But with 6 times a week dialysis, herself and her husband were getting a little bit slowed under with all the therapy, and we agreed for her to drop to 5 times a week, but with 3 hours per session. She continued to improve on this regime, improved her mobility to just using her stick, and had no breathlessness and no signs of fluid overload. At this point, we'd also managed to reintroduce her ACE inhibitor. And I'm pleased to say that she sustained for a further 2 years on this regime at home with exactly 0 hospital admissions. Now, coming on to case 2, which is a case that will be familiar to all of you, but actually looks more at right-sided cardiac failure. This is the case of Mrs. X, a 72-year-old female with end-stage renal failure due to chronic glomerulonephritis, who, at the stage of her renal failure, spent her first year on peritoneal dialysis. She then had a living-related transplant, but unfortunately this was complicated by malignancy. And after reducing her immune suppression due to her malignant melanoma, unfortunately her transplant failed. She went back onto peritoneal dialysis at this point, but really failed to thrive. She was accumulating fluid and losing her albumin and really not thriving on PD. So we transferred her over to incenter hemodialysis in 2012, and initially things improved. However, she was coming into her hemodialysis sessions extremely hypertensive. She was taking an ARB and a calcium channel antagonist, but both of these were subsequently being stopped and started due to high blood pressure and then dropping her blood pressure on dialysis. She was remaining extremely hypertensive between her dialysis sessions, but we were not achieving her target weight due to dropping of blood pressure. Again, looking at her function, her echocardiographic data show that she had a preserved ejection fraction at 70%, but with raised pulmonary artery pressures at 60 millimeters of mercury and severe tricuspid regurgitation. She had a moderately dilated right atrium and raised right atrial pressures. At this time, she was doing hemodialysis 3 times a week via a tunnel catheter. As I said, we were stopping and starting her antihypertensive medications, and she had symptomatic hypotension, but did not tolerate the UF well and was fluid overloaded in between sessions. By 2015, her echo parameters were worsening further. Her pulmonary artery pressures were up to 77 millimeters of mercury. Tricuspid regurgitation had worsened, and she now had severe biatrial dilatation with right atrial volumes of 71 mils. She couldn't tolerate her ARB, and just a small dose of beta blocker was all we could achieve. And at this point, she'd now had a fistula fitted as well. We discussed with her a transfer to home hemodialysis, where her and her husband agreed to do 2 hours 6 times a week. At this time, she was significantly breathless. She'd developed severe ascites and actually had required several paracentesis to deal with this, despite having a normal liver, normal LFTs, and at this point a normal blood albumin. Again, I just draw your attention again to this schematic that was showed by Dr. Collins, and just to remind you of this pressure building between dialysis sessions, particularly affecting the right side of the heart. So it is that volume loading that we see with our patients that causes abnormal cardiac pressures. And again, that loading between sessions that expedites this and makes it worse, and that 2-day gap leading to the highest pressures between cycles. But again, just reminding you and putting it into context of this lady, she really did have this uncontrolled hypertension, which was worsening her cardiac function, worsening her heart failure, and leading to more and more hospitalizations and increasing her risk of death. But equally, even though her problems were predominantly right-sided, we were still seeing this issue with the unloading side of the cycle, with high ultrafiltration rates, not tolerating the fluid off, developing symptoms, and again perpetuating this chronic fluid overload cycle. Moving on for her, a year on frequent dialysis at home, she was up to 6 2-hour and 45-minute sessions. We'd managed to reintroduce her ARB, and you can see that she still had preserved ejection fraction, but crucially, we had now seen a significant reduction in her pulmonary artery pressure down to 21, an improvement in her tricuspid regurgitation from severe to mild, and she had normalized her right atrium, still with slight increase in her volumes, but with a normal size on echocardiograph. She had a massive reduction in her ascites and required no further paracentesis, and a major improvement in her shortness of breath. She carried on for the next 3.5 years on home hemodialysis with excellent outcomes, no more ascites, no more shortness of breath, and an improvement in her overall exercise tolerance. She slightly reduced her therapy down to 2.5 hours, but maintained 6 times a week. And we managed to get her back onto a good dose of ARB, a calcium channel antagonist, and a small dose of beta blocker to improve her parameters. And you can see by now she's completely normalised her pulmonary artery pressures and indeed her right atrial pressures as well. So really, to summarise, I hope what myself and Professor Collins have shown you is that cardiac disease remains one of the leading causes of mortality in our dialysis patients. And the accumulation of their pre-existing disease, be that heart failure, arrhythmias, cardiovascular disease, diabetes, and then the addition of this chronic volume overloading state coexists in most of our patients. And improving volume control is achievable, but frequently requires us to deviate from standard hemodialysis prescriptions in order to facilitate the fluid off, reducing the ultrafiltration rate and improving the outcomes for our patients. And really, I hope what I've shown you with this is that the two key things in these individuals is volume control. We will get the clearance that we need if we strive to get the volume control so that our patients can tolerate a decent dialysis session. And equally, how crucial it is to be focusing really on that symptomatic control of our dialysis patients, because good control of symptoms will indeed help the patients to be able to tolerate more dialysis and get the better outcomes that we require for these individuals.
So thank you, Natalie, for this interesting talk and your case histories. It is now time for your questions to the two speakers. We have received many questions from you that I now will address. The first question is for you, Alan. Is there any comparison or study about patients with peritoneal dialysis and cardiac overload?
So that's a great question. There's no comparative studies with peritoneal dialysis. The degree of cardiac and fluid overload, however, was recently published with the iPod study June last year, which showed that on average, the peritoneal dialysis patients start peritoneal dialysis about over 3 kilos overloaded. And those that, and this was demonstrated by the use of bioimpedance measurements. And then even after a year, those that were persistently fluid overloaded were as much as 2.5 to 3 liters above where they were over time. So that the peritoneal dialysis patients have a similar problem with fluid overload over time as the dialysis population has. And that, I think, is the common thread between the two types of treatments, that the PD loading is slower and more chronic in nature over time, whereas the hemodialysis loading is cyclical throughout the week and occurs week after week after week with unrelenting over time. Yet the two populations still wind up after 2.5 to 3 years with the same cardiovascular mortality rates and event rates. So the loading in both of these populations is a problem, and there's no good alternatives to deal with loading right now in the PD population.
Thank you, Alan. Great answer. We have another question for you. To provide and support more frequent and effective hemodialysis, how far are we to enable the therapies at home and more personalized treatment?
Actually, this is a great question for Dr. Borman, who has a very large experience in this. So I don't have to give you my thoughts on it. Let's give you Dr. Borman, who actually applies this every day of the week.
Thank you. Thank you, Alan. What I would say is I'm a huge advocate of personalised hemodialysis therapy, and I think it is really tricky to provide this in our in-centre hemodialysis units. You have some flexibility, but the majority of us struggle to provide anything more than standard dialysis there. So when we send our patients home from our centre, we try and advocate frequent or, where possible, nocturnal therapy. But I'm a believer that we should be working with our patients to find a therapy that satisfies their clinical needs, but also meets the demands of the patients. There is no point in us prescribing them a therapy which they will not do. But equally, it is crucial that we have an understanding between ourselves and our patients as to why this type of therapy is beneficial for them. So if you take the cases that we've discussed today, it is all about the fluid control. So there is no point in them going home on a 3 times a week therapy unless it's for protracted hours such as nocturnal, because we are trying to aim as our main goal being volume control. In other individuals on home hemodialysis, the goals may be very different, and therefore you may want to look at a different regime. But I think it needs to be a combination, or a meeting of minds, as I like to call it, between the goals as us as their clinicians and the patients as individuals and their lifestyle.
So the next question is for you, Natalie. So how many days or weeks are needed to educate and train a family member patient to enable dialysis at home? What is your experience here?
So again, I guess that follows on nicely from the last question, because I think we need to go into training with our patients and their family members and really be looking at an individualised plan, because the last thing we want to do is rush training, but equally we shouldn't be dictating that patients need to spend weeks and weeks in a training facility if they're ready to go at home. By taking this approach and being hands-on with our training from day one when our patients come to our centres, we actually have an average training of just 9 sessions for independence at home when patients are already established on hemodialysis, including the cannulation, and around 4 weeks for those individuals who are completely naive to dialysis who come from our advanced kidney care clinics.
So how often do you encounter patients that is unable to train for this, that you have to stop the training? Is that happening sometimes?
So in our centre, we have now trained more than 350 patients, and our failure rate for training is around 8%. And the majority of our patients who have failed have been elderly patients reliant on an elderly care partner who have had their own health problems as well. But in the majority of cases, we succeed with training in these individuals.
And also the next question is for you, Natalie. How about the vascular access survival with daily home hemodialysis sessions?
Yeah, so we have a ever so slightly increased infection rate in our home patients on fistulas, but it is very marginal compared to our in-centre patients. Most of our patients on a fistula at home use the buttonhole technique. We find that the survival of the fistulas is as good, in some cases, if not better, than in our in-centre patients. We do monitor them regularly with our transonic monitor, 3 monthly for standard patients, monthly for patients with a graft. And we think that the vascular access surveillance with early intervention with fistulograms, fistuloplasties as required, helps to prolong their survival of access at home.
Thank you. Well, there are many questions for you, Natalie. So the next one is how big is the impact of increased quality of life on overall measures?
So I think that this is the most important outcome of dialysis, and I think it is still under-recognised and under-reported. Certainly, to me, the quality of life of my patients on therapy is paramount. And you can see that from the case studies that we've shown, because actually I think the patient's quality of life, and particularly symptoms on dialysis, actually equates quite nicely to what we're achieving in their other parameters. You rarely get a patient who has terrible cardiac function who reports feeling great on dialysis, or who's chronically volume overloaded. Equally, those patients who are dropping their blood pressures feel bad as well. And what I found with patients going home is patients actually feel better when they're doing more frequent dialysis and are then more compliant with their therapy than previously. And I think it is an impact measure that should be reported actually in all of our patients and at registry level.
So for you, Alan, so you're not going to sleep. Here's a question. Are there any cardioprotective drugs, measurements available that might reduce cardiac overload?
So this is a great question. So this question should be really divided into two parts. There's cardiac failure with preserved ejection fraction, Natalie's second case, which is mainly right heart failure. Then there's cardiac failure with reduced ejection fraction. So all the studies have been done in the general population, not in the dialysis population. The drugs that you're very familiar with that work with heart failure with reduced ejection fraction is the ACEs, ARBs, mineralocorticoid receptor antagonists, etc., vasodilator therapy, beta blockers. There are no drugs, 0 drugs. To make this absolutely clear, there are no drug treatments for so-called heart failure with preserved ejection fraction. The only thing that works in that setting is control of volume and blood pressure. Those are the only two things that actually work in diastolic heart failure. So you can see that our dialysis patients actually have a fair amount of diastolic dysfunction in heart failure, where volume control and blood pressure control is really the central element. What I think Natalie's cases point out, that if you have cardiac protective drugs that could be used in those with reduced ejection fraction heart failure, they're frequently not used because they're having hypotension on dialysis. And when you can improve the volume control and their blood pressure stability on treatment, you can reintroduce the cardioprotective drugs that have been shown to be efficacious in the general population for those with reduced ejection fraction. Just to make it clear, there are no drug therapies for heart failure with preserved ejection fraction, only volume control and blood pressure control.
Well, I'm glad there are so many questions for both of you. Next one is for Natalie. What about environmental aspects of daily versus long alternative day nocturnal hemodialysis?
A very interesting and very topical question, because obviously we all want to be striving towards a more green dialysis. And I think what I would say from that perspective is the benefit you get environmentally with your longer dialysis, alternate day nocturnal hemodialysis, is obviously you use less consumables. So you have less dialyzers, less sets, less needles, etc. So less clinical waste for those individuals. In terms of other things, you are probably using the same volume of fluid, so it is not more water smart, although you're not using less electricity for longer sessions. And certainly the machine we use on dialysis at home in our centre is both water and electricity smart to start with. But of course, you do have the option of reducing your daily consumables if you're doing longer alternate day or nocturnal therapy. In my experience, for reasons that I'm still trying to explore, it's still quite difficult to convince patients to do prolonged hours and overnight therapy. We've done some work on that in our centre, looking at patients' attitudes to doing nocturnal therapy even when they're on a home therapy, and it often is that nervousness of dealing with alarms overnight, dealing with needle dislodgement, and dealing with emergencies when they've previously been asleep.
Yeah, this is an increasingly important aspect of dialysis treatment. So this is a question for both of you, and we can ask Professor Collins first. In areas where dialysis modalities are restricted to conventional incenter hemodialysis only, what do you advise to dialyze a patient with severe heart failure?
Well, that is the dilemma. I'll go first and Natalie can chime in. The typical 3-time-a-week schedule is obviously not working for these individuals. The choices you have is either increase the length of each treatment, which also causes a huge number of logistical problems for the patients and the dialysis unit. Increasing the number of treatments per week is also a scheduling nightmare with conventional therapy. But at a minimum, a fourth treatment per week can actually be helpful. The problem is to figure out where are the open slots and time intervals where this fourth treatment could actually occur. Alternatively, I would suggest to you that conventional or in-center treatments have other opportunities during the evening hours, overnight. You could do nocturnal treatment in the dialysis unit itself, and you could do the fourth treatment overnight as well. Lastly, there are community center type settings, sort of self-care settings, where hemodialysis can be performed with a schedule and a cost structure that is less demanding than the conventional in-center setting. I think the severe heart failure population that's dialyzed conventionally 3 times a week is very difficult to manage.
So Natalie, do you have anything to advise regarding this question?
I think I just echo everything that Alan has said here, which is, the ideals here are either more frequent or longer duration dialysis. And certainly I would really like to see a move across the globe at looking at in-center nocturnal therapy for these patients that are unstable, because we're filling up the chairs, but we have this great 12 hours overnight where nothing really happens in our dialysis centers generally.
From that standpoint, if I could add one more comment, Peter. This idea of hybrid therapies, within the center itself, is actually something that has been discussed with my colleagues in Japan, where you take advantage of, let's say, 3 times a week shorter treatments, and then make it up with nocturnal treatments the other 2 or 3 nights a week, such that they get certainly the solute control, but they get significantly more opportunities to manage volume. So I think the in-center rigid way by which it is scheduled right now, 3 shifts at most in a day, as Natalie has pointed out, vastly underuses the opportunity for the nocturnal period.
So more flexibility is needed.
Yes.
So Alan, this is a question for you. Are there any studies looking at overall cost comparing home hemodialysis with in-center dialysis?
So it's a great question. There was actually a study published last year in Canada. Paul Commenda was one of the co-authors of that study, which compared the more frequent home hemodialysis in their setting. They were doing it 4 times a week in Winnipeg, Canada, compared to their in-center hemodialysis population. Now, when you compare the cost structures of these, you have to remember to take into account all the costs. This is not just the dialysis itself costs, because in center you have staff costs. You have the overhead of the unit. You have all the water treatment, everything else that's going on in center. In the home setting, remember the staff costs are mainly only the training costs and then the monthly calls or visits or from the staff. So staff cost is substantially less. The overhead is substantially less because you don't have a large 12-station dialysis unit that you're trying to fill. You have the patients that are delivering their therapy by themselves with their partners at home. So that study showed that actually the home hemodialysis is less expensive than in center, but the least expensive of all therapies at home is peritoneal dialysis, because you don't even have except for the cycler, CAPD is the cheapest of all the home therapies. Once you add the cycler, then you have another incremental cost there. So it's not less expensive or equal to PD, but it is definitely less expensive than doing in-center.
And just to add to that, there was also there was also a UK study published, I think, in 2018 in the British Journal of Hospital Medicine that compared in-center versus home hemodialysis. And just to echo what Professor Collins is saying there, it is that bigger picture. It's looking at your infrastructure, your staffing, your transportation costs, And certainly it is very economically viable when you take all of those into consideration.
Again, a question for both of you. What is your opinion on combining peritoneal dialysis and in-center hemodialysis in areas where home dialysis is not available? Alan, will you start?
Well, let's let Natalie tackle that one.
Okay,
She's probably
Natalie,
thought of this one.
it's for you.
I have to say, before we had our home hemodialysis program up and running, we did this on a couple of occasions. It's always a really tricky one because when peritoneal dialysis is working well, we know that it's a great therapy and it can sustain people. But by the time we're starting to put incenter hemodialysis in, the PD is usually not working as well. And we're usually at the point where we've exhausted more bags, more duration, APD, more rapid exchanges, whatever it is that we can do. So in a couple of occasions where we've tried this, what we find is when they start the incenter dialysis, residual renal function disappears, and actually the peritoneal dialysis is then not adding sufficient to justify the either the demand on the patients or, unfortunately, I have to say, the cost of delivering both therapies concurrently, which, certainly in a healthcare model that we have in the UK, and I'm sure everywhere else, we certainly are not funded for both therapies happening at the same time. So it's a tricky one to make an argument for.
Well, with this, I would like to thank both Professor Alan Collins and Dr. Natalie Borman for all these good answers and also for your interesting lectures. And for all of you, I'd like to thank you for joining us in this third webinar in this series. I'd like to state that the next webinar, which is number 4, will be on October 29th with Professor Malamachi and Dr. Trepepi, and they will address exercise and physical health on patient outcomes. Thank you for joining us today, and see you October 29.